Ladies and gentlemen, boys and girls, welcome to the September 2024 Editor's Insights, Episode 1 of the Indian Journal of Anesthesia podcast. It's our privilege today to have, along with Dr. Rakesh Garg, the Editor-in-Chief, Dr. Hari Kalagara. Dr. Hari Kalagara is an esteemed Assistant Professor of Anesthesiology at the Mayo Clinic, College of Medicine and Sciences, and a consultant in the Department of Anesthesiology and Perioperative Medicine at the Mayo Clinic, Jacksonville. With an extensive background in anesthesiology, critical care, and pain management, Dr. Kalagara has earned numerous accolades, including the Best Resident Award at Cleveland Clinic and Excellence in Teaching Award. He is a certified expert in perioperative transesophageal echocardiography and regional anesthesia, holding prestigious board certifications from both the American and European societies. Dr. Kalagara has been deeply involved in pioneering educational initiatives, particularly in the field of point of care ultrasound and regional anesthesia, where he serves as a course director and faculty member for several international workshops and meetings. In fact, if I'm not mistaken, he has spent the last 3 weekends teaching POCUS in various continents. He has also contributed significantly to advancing anesthesia practices with his leadership roles in key medical societies, including the American Society of Regional Anesthesia. Dr. Kalagara's work extends beyond clinical practice, with active involvement in research, contributing to numerous peer-reviewed publications, including articles on regional anesthesia, POCUS, and also impact of innovative ultrasound procedures. His dedication to education and mentorship, along with broad expertise, makes him a highly regarded figure, not only in clinical community, but also academic communities. The reason he is here is he wrote an editorial for the Indian Journal of Anesthesia in September issue, along with Dr. Surya Kumar Narayan-Swamy, on perioperative glucagon-like peptide 1 receptor agonists induced gastroparesis. Is gastric ultrasound the answer? To discuss more in detail about this, he is here with us. Thanks a lot, Hari, for joining us.
Thank you, Dr. Murali Thondebhavi and Dr. Rakesh Garg. It is an honor to be part of your podcast and to talk on behalf of Indian Journal of Anesthesia. It's my honor and it's my duty and right that should contribute to the Indian society because that's where my roots came from. So very glad to be part of your series. And thank you for your kind introductions as well, Murali. You're too kind.
Thanks a lot for joining. Dr. Rakesh, do you have anything to say as an introductory remark to Hari?
Thank you so much, Dr. Hari Kalagara. Your editorial was really very informative, and I can say it has actually brought about a turbulence in the academic forum for discussion on this aspect, because you have really touched many important aspects into this editorial, and I'm sure that it is long way to go for its utility. And your editorial is really creating a lot of research ideas among the various persons, and it is being discussed a lot across various academic forums.
Thank you.
Dr. Hari, we'll get started with the conversation with a question which I'm sure every listener wants to know. We are talking so much about POCUS, so many workshops happening about POCUS. Now, you teach across all the continents, whether it is South America, Europe, Asia, and you've seen so much of POCUS training happening. How has POCUS transformed perioperative care across the world, from your experience having seen so many places?
That's a good question, Murali. In the last decade, when we used to do these courses or when we used to talk about point of care ultrasound, the main barrier was lack of ultrasounds in the countries, especially in the developing countries. Now, in the last 2 or 3 years, if I move across, come to India, nobody says I don't have an ultrasound machine. That is a big game changer for us to move forward in education, teaching, and implementing point of care ultrasound in clinical practice. It's universally available in most countries except a few African countries or South American countries. So that's a good thing. As we see, focus is not just scanning the heart or anything. If you use an ultrasound to achieve your clinical success in diagnostics or interventional, they call it as a focus. For example, if you are struggling to get an arterial line and use an ultrasound to get your arterial line or difficult IV, that's a good use of a focus. That's one thing. So people need to think the starting where the focus starts from, how it is enabling you to achieve the success. And the second classic example I tell to people is when we do regional anesthesia and OB anesthesia, we encounter difficulties to doing a spinal or an epidural. Just identifying the midline, you're struggling. Use your ultrasound and to identify the spine or epidural space, especially the midline. If it increases your success, that is a good utility of point of care ultrasound. So actually, my first article on point of care ultrasound was written on spine. That became very, very popular because we did it a very nice extensive. Then it went forward. So that's what I want to get an idea to all the participants or viewers. Focus is if you use an ultrasound at the bedside with the patient at any given clinical point in your clinical practice, that is focus, and you are moving into that direction.
So you did speak about the advantages it has over traditional diagnostic methods or traditional techniques that we use. Now, what about various patient populations when it comes to, say, risk assessment before taking up for anesthesia? Now, is there any role? Now, we are coming to that role in this editorial. That's why I'm asking you this question.
Exactly. So certain things, Murali, if you see how the COVID has affected our lives and 2-3 years back, how COVID has really stuck into the clinical practice, that's where the focus has got the biggest boom and starting point. Just for example, patients all had COVID pneumonia, they need to CT, MRI, which is very time consuming, lot of cost involvement as well, manpower and stuff. Lung ultrasound at that particular point in the intensive care units was revolutionary, game changing. The max articles in lung ultrasound on point came during the COVID. It helps to risk stratify the patients, to know who is really ill, who needs ventilatory management. It guided everything, not going for repeat X-rays, repeat CT, and repeat MRIs, which has a huge impact even on radiation effects, cost, manpower, and everything. So that is one classic example how the pandemic has changed everyone's perspective onto the extensive imaging and using point of care ultrasound at the bedside. First, second thing, as common to our editorial now, what we are talking, what we have written, if you see in the United States exclusively and most of the other parts of the world, I'm not sure about how in India the GLP-1 medications are being used and picking up, which I might take your thoughts into that. So we now encounter almost 1 in 20 patients with one GLP medication. It is becoming a fascinating trend here. If you see the most popular 25 drugs being used in the United States, GLP-1 agonists are number one being used in the United States. Within the last 1 year, its use has been dramatically being increased just for reasons of obesity and for diabetes. So many other things, but I'll come to these two. So this is where in the last 2 years, the point of care ultrasound limited to gastric, which we call a gastric ultrasound or gastric focus, has been extensively being increased in usage, education, training, when, what to do, how to do. So that is one exponential growth, COVID and GLP-1. These are the two classic examples I can tell you how we are trying to reach and train all the physicians.
You're talking about the increased usage of this GLP-1 receptor agonists. Now, for all our viewers and listeners, can you just explain what this GLP-1 receptor agonists are and what are the key differences between, as you mentioned in the editorial, the short and the long-acting ones?
Yes. Let's say GLP-1 receptors are usually in the natural hormones secreted in our body, especially in type 2 diabetes. It's being decreased in secretion. So what happens is you give the GLP-1 receptor agonist, which mimic the internal hormone and helps you to control the blood sugar. It is the main concept of the GLP-1 receptor agonist. It's been almost started in 2005. We are talking after 2 decades, which is very, very unfortunate. So, but the long-acting came into use in 2017, but actually the first indication for diabetes was started in 2005. So there are 2 different varieties. We divide them into short and long-acting. Most of the long-acting are given by subcutaneous injection once weekly or once in 5 days. The oral ones can be given daily, short-acting ones. So these are the 2 different formulations that are being available. The recent trend has been because it has been FDA approved for obesity. And we all know, we are all want to eat, don't want to exercise, just want to take a tablet to have cut down our weight, which is not the best way, but it has grown. It has been impressive, I'm telling you. The people's weight loss with this medication is amazing. The reason is they feel for weight loss is these medications, they delay gastric emptying. They feel you increased satiety. So you have some added advantages, but in our perioperative period for us, because of these delayed gastric emptying, we have consequences of aspiration pneumonia. So that's where we are coming into the perioperative risk. So the short-acting ones, if you take orally, sometimes the blood concentration goes down to 0, and then the blood concentration comes up. So the long-acting ones, what we talk are, if their blood concentration doesn't come to 0, they still have an active blood levels, we call them as a long-acting. It doesn't matter the duration. If they have a plasma concentration, which is an active, we say them long-acting. If it comes to 0, we tell them short-acting. Some people take it as once daily medications as short, but it may not be true. So that's how we divide these 2 medications. But unique advantages and disadvantages are there. Once weekly, easy for the patient to take 1 injection once a week. That's a good thing. And if you look at the profile, these both medications, long-term medications have a better control on HbA1c, better control on blood sugar, and in the long term, may have a less delayed gastric emptying. So because of the major benefits, people are getting more of a long acting rather than a short acting on a very certain group which gets short.
In your editorial, you mentioned a case report which was published in March 2023 by Klein and Obai et al. And it was about intraoperative pulmonary aspiration with usage of semaglutide. Now, I think that opened the initial Pandora's box on this subject. Now, coming to an anesthetist who's working, now I know that in India also the usage of GLP-1 RAs are increasing. How do you recommend an anesthetist, which is this case, like you sees a patient the previous day, patient is on semaglutide or one of these long-acting GLP-1 RAs. What kind of a fasting protocol should be considered? Now, that is again another thing which you have raised in the editorial, which is creating a lot of discussion across various social media platforms. So how should the standard fasting protocol be considered?
Thank you, Murali. It's really a great question, but I think I may not have a complete answer, but I will try my best what is currently available. And in this particular instance, I want to thank my co-author, Dr. Surya Narayana. He did an amazing job along with me in doing and writing the literature research and everything. So thanks for Surya as well. The thing is, 2023, when this case report in CJA came up, it was like as you told, it was open the Pandora. Then another case report was published in Anesthesia Patient Safety Foundation in the US with the big images, how the aspiration occurred and everything. Everybody were like, okay, I became an IOP. So in June 2023, the American Society of Anesthesiologists, ASA, because of these case reports, because of this aspiration risk, came out with some guidance for all of us, telling that if the patient is on a daily medication, stop for a day. If the patient is on weekly, stop for a week. It is a temporary guideline that came up, at least to have some sort of guidance. This is the first time society has acknowledged to use gastric ultrasound. In these guidelines, they made recommendations to stop medication for a day, for a week, based on the use. Then, based on the symptoms, if they are not being stopped, they said use gastric ultrasound. Based on your gastric ultrasound evaluation, proceed ahead to prevent pulmonary aspiration. So this all happened at the same time within 2 to 3 months. But the problem is, I'm not here to criticize any guidelines or anything. It was a great starting point, I would say. But the problem is, if you look at the pharmacokinetics and dynamics, stopping a medication anything less than 3 half-lives is not valid. You are not doing a great job. For a medication with a half-life of 7 days, if you stop at 1 week, you are doing only a one-third justice. So actually, you have to stop at 3 half-lives for any medication to have a negligible clinical effect. So we got a lot of letters were being written and everything. But the problem at that particular time is there were no studies. Nobody did a randomized studies. Nobody has studies. We only had a case reports. So that's the scenario. Moving forward now, we are having more studies. So I can talk about it very soon. That's where we are more.
If somebody doesn't have a gastric ultrasound, let's take that into consideration, and we have stopped this long acting for a week. Do you suggest they go ahead with a rapid sequence induction?
So that's for me. I'm a strong believer of stopping for 3 half-lives because I believe more of a pharmacokinetics. So if any person didn't stop for 3.5 or 3 half-lives, I always say consider patient didn't stop the medication. And the second thing I always say is consider the patient's clinical signs and symptoms. Is he feeling nauseated? Is he feeling or is he throwing up? Is he feeling bloating in the abdomen or any abdominal pain? If those symptoms are not there, the patient is being fasted, then you can take a gamble. Even if you see the studies afterwards, especially the one published in JAMA by Sen et al., and then followed by Sherwin et al., published in CJA, both in 2024, both the studies were done on patients on GLP-1 for a week, repeatedly fasted for 8 hours, had 50% of residual gastric. So they followed the guidelines. They stopped it. They were fasted. Still 50% of them had residual gastric. So it is a non-conclusive. Now we are looking at how much duration we really need to stop. Is how much fasting do we really need to do? These are the two big questions we need to think.
Considering the mortality is very high if there is a pulmonary aspiration close to 57%, I will take that as an answer from you that if they have not stopped for 3 half-lives, consider a rapid sequence so that patient is safe and you are safe at the end of the day.
Exactly.
Now, yeah. So now in your experience, how effective is gastric POCUS? You've been doing gastric POCUS for ages now at identifying this residual gastric contents. You do talk about false positives, false negatives in editorial, very well written. So what is your take on this? Should it become a routine? Now, this is a very controversial question I'm asking now. So should it become a routine part of preoperative assessment, patients on these medications?
Thanks, Murali, for bringing this up. So what I would say is, based on my teaching experience and my thing, so what I always say is one of the easiest modality to learn in POCUS is gastric. So easy. It's one we teach, and the participants go and learn. Even the learning curve we say for people is 30 gastric ultrasound. So if you do 30 scans, you almost achieve 95% of the competency with the skill where you are. Certain patients are difficult, like morbidly obese, or certain patients are difficult, even someday I may not get it. That's an extreme outliers, but is one of the modalities that can easily be learned and see. Second thing I always say is, if you are in doubt, save the images and ask or refer to an expert. What do you think? What do you think? It helps you to attain more skill. So if you scan and you don't save, you don't ask for expert help, you are left with unknowns. As like any test, you need to put the clinical context into picture. Don't treat the image. That is what I always say. Look into the clinical context. And second thing is the more you do, it's getting very useful. And coming to implementation in clinical practice, I can definitely say in most of the hospitals in US, it is becoming a standard of care. Any patients on a GLP-1, if you don't have a standard protocol which says this is perfect for the patient to be fasted, they need to do a gastric ultrasound. For example, in our hospital, anyone on a GLP-1, we are a group of people, get a phone call, we go scan the patient, then the patient rolls into the operating room. So I'm doing these courses for the ASRA courses now from the last 5 years. In the last 2 years, people are coming only to learn gastric ultrasound because their departments are in need of the experts to learn and implement into those. So I would say in a matter of time, it's already a standard of care in some of the places, but not everywhere. If the learning improves, people are trained, it will be a standard of care in this subgroup of patients, especially rule out and rule in.
In fact, you might, as you said, see guidelines in the future which come out with, yes, these patients are coming to the operating theater. If they're on these medications, if they have these comorbidities, kindly do a gastric ultrasound to ensure. I think that might be coming up in the future. And for all our listeners and viewers, Dr. Hari is one of the most active people on social media, especially on Twitter. So if you are doing a gastric ultrasound and you have an image and you need an expert to kind of opine, I'm sure Dr. Hari wouldn't mind giving a couple of opinions or giving his thoughts. So all you have to do is post the image on Twitter on your Twitter handle and just tag him. And I think he's 24/7 on active on Twitter, if I'm not mistaken, Hari. So he'll definitely reply back and give you an opinion on that. So going forward, I request Dr. Rakesh to ask a few questions, mainly regarding research in this front. Dr. Rakesh, over to you.
Thank you, Dr. Murali. Thank you, Dr. Hari, for bringing this important aspect of a newer drug with newer indications, which we are talking about. And I'm really amazed by your enthusiasm for using POCUS, both for academics, clinical research also. There must be some niche area. If I see the articles which have been published across the journals in the last 5 years, they are coming up. But I also see that they have a lot of limitations there. And when we talk about, you were talking, Dr. Murali was asking about the guidelines and the standard of care. So when at some institutes or universities, they want to change their practice, they need some solid platform. And in research, we say that it has to have a strong evidence. And maybe unfortunately, or we are coming up in coming times, a meta-analysis that will give us a grade A evidence, level 1 evidence for confirming something. So based on your experience, what will you suggest to our IJA readers and researchers that what are those niche areas where future research are possible that will give us a robust platform that yes, this is level 1 monitoring tool in the perioperative period for any perioperative physician.
Thank you, Dr. Rakesh. The important thing for some of these limitations for this study is what is your endpoint? So most people, they always say, oh, you say it is an increased aspiration risk. So, but looking at an aspiration as an endpoint, we need a big study. Power is like unbelievable. And you can do a randomize people into 2 groups where we have increased residual contents to one group without doing a rapid sequence. It is like a parachute study. So you can't do. So there are limitations to do studies and there are limitations how people move forward. The important things to look for us is I think most will be a retrospective data will be coming up. A lot of retrospective studies will be coming. Data are coming. Even the endoscopy suits, even those people are started publishing. If you look at the journals of gastroenterology, endocrinology, publishing a lot on GLP-1. So it's not only anesthesia. Everybody is coming up with their own articles and everything. So we recently at our Mayo, 3 centers, we finished a big retrospective study. We are coming out. We completed another multi-center study on behalf of ASRA and ASA. We completed that study. That study is going to come up soon. In 7 centers, we did a multi-center study, which I cannot disclose both the results. Wait for those which are coming up. As you said, on behalf of American Society, as Murali has already insight into it, he already guessed it. We did a big systematic review and the guidelines are coming up. When to use gastric ultrasound. We did on pregnancy, obesity, GLP-1, and GERD. We looked into 6 to 7 specific populations, and we did a systematic review and meta-analysis, and we already got all the work done. So wait for it. Maybe in the next 6 months, the big guidelines on gastric ultrasound first time are coming.
Absolutely. I think this is a wonderful news and must be very useful. I think at this point, I can take a liberty to ask some pre-release of this guideline to you. We have talked about the GLP-1 receptor agonist. What other drugs or clinical conditions do you think will have, say, similar gastric paralysis or delayed gastric emptying? So, I mean, I need to just be very clear that, yeah, routinely patients, ASA1 patients, we are not much concerned about aspiration if they have been fasting for 4 hours or 6 hours sufficiently. So which other clinical scenarios you think where they will have definite role? I understand it should be for all patients, definite role for using POCUS for this purpose. This is one. And second, I wish that there will be something. We are using surrogate markers. We say that this much is the antral diameter, or this much appears to be radial, or there are heterogeneity into the ultrasound picture. These are all surrogate markers for possible aspiration. So are you and your team, and I wish, can have some definite markers which could be used for research purpose to say that this much content, this much diameter, this much heterogeneity in the ultrasonography would be an indication that this patient is at high risk of regurgitation and aspiration.
That's it. Yeah. So currently the one clinical condition I can say for sure is type 1 diabetes, gastroparesis. That will be a strong indication for gastric ultrasound moving forward. That's one clinical condition I can say. Type 1 long-standing gastroparesis, especially if they're on gastric paresis diagnosis with gastric pacemakers. Second thing we always say is chronic renal failure, chronic hepatic failure. Those are the 2 things we say. We didn't see much clinically of a bigger impact of those 2 conditions. They are encephalopathic with the liver failure, maybe, but simple liver failure or chronic renal disease didn't have much of an impact. So along with the GLP-1, the second biggest group will be the long-standing type 1 diabetic patients with gastroparesis. They'll end up having a routine gastric. That is the 2 groups I would say. The problem with this GLP studies are, Dr. Rakesh, is what dose they get the tachyphylaxis. How much duration they are on. Currently, people are thinking if they are on for 12 weeks, they don't have a delayed gastric emptying. But if there is a dose escalation from that, they still have a delayed gastric emptying. So the things to look are just not on GLP-1. Is like how much dose, is there a recent escalation? Okay, is there any tachyphylaxis? Is the oral route versus subcutaneous route has any difference? And the second thing now we think is stop solids for 24 hours and we are keeping them on a liquid diet for 24 hours. Especially we had a big instance of cases in the GI where these patients are coming in, routine fasting, stop, still full stop. So then we decided no solids for 24 hours. So will that be the future standard? We don't know. All the studies will help. So stopping for 8 hours in certain patients with high dose of GLP-1 is not enough. So especially the patients, simple example, the patients who are having colonoscopy, they drink a prep for at least 2 to 4 liters the night before. They're coming in the next day, completely full stomach. All these cases you just do under sedation. And now they are full stomach. Will you take a risk of doing them under sedation with having this much of gastric antral volume? So now coming to your question of gastric antral volume, based on all the studies, he thought Dr. Perlas and group has come up to a conclusion. If the antral surface cross-section area is more than 10, they are at a high risk. So initially between 6 and 10, we used to think about, now we say, if the gastric cross-section area is more than 10, they are definitely high risk. At the same time, if you see the residual gastric contents as solids, they're at high risk. But the problem is, liquids can aspirate fastly, solids may not. Every residual content, that means may not aspirate. That's the thing. But if the solid aspiration happens, the mortality is 10 times more than a liquid aspiration. They almost end up in an ECMO. If you see the latest OB literature, the retrospective data last year in OB, the number of patients that went on ECMO, the second common cause was pulmonary aspiration. Still, in spite of doing a rapid sequence in OB, still they have pulmonary aspirations, and still the second common cause to end up in extracorporeal membrane oxygenation, which is the deadliest machine you ever want on a patient because of aspiration.
With the variety of cases and the high-risk population that we are catering now, because medical science has improved, surgical practice has improved, so we are venturing getting ASA3 and ASA4 patients quite routinely. So I think you are absolutely right in that sense that we have to look for all those preventions and precautions. But having said, just a last question from my curiosity. I remember my old PG days when we write to the preoperative orders. Usually, a prokinetic agent used to be a part of the preoperative order. So, do you think when we talk about the drugs which are delaying gastric emptying, is there a role when we talk about POCUS to write them routinely or specifically the prokinetic agents like metoclopramide, which people have been using it? So, what's your take on this important aspect? Because I have not been using them regularly now. In old days, I was a regular prescription of writing Perinom HSN in the morning, not using it. So what's your say?
Fantastic question. This is a common thing we get to ask to, especially in pregnancy. You give Reglan and you give the metoclopramide, and that's our normal say. In GLP-1, if you look, the recent paper from anesthesia came in May 2024, and this review article, they pulled at all the studies. They came up with nice guidelines. In that paper, they suggested using metoclopramide 10 milligrams before. Have tried in a certain patients. If the residual contents are liquids, you give it, wait for 2 hours, they have some effect. But the mechanism of metoclopramide and GLP agonists are completely different. So in some solid state patients, it didn't have any effect. Zero. If they had liquids, and if you give more time, it's not just you give metoclopramide within 10 minutes, you take them. No. You need to wait at least 2 hours. So the answer is yes or no. You can try it, but don't take it has a good clinical effect and go for it.
So
it may not have.
The focus will be again here that whether metoclopramide is working or it is still there.
So that's what I do for my patients. They come in full stomach, so they are very upset if we cancel them, we delay them, we give a metoclopramide, rescan, everything is fine, good. Especially the situation comes in the elective cases. Do you really need to take up with the risk, or do you do a rapid sequence, you are good enough and you carry on? Don't know. If you still do a rapid sequence, if the aspiration happens, then what? So emergency, yes, you carry on, you secure your airway, you don't do without a protected airway. I can understand. We do it, we do the best job. For an elective, the situation comes, now you have a full stomach patient. Not, you still did it, aspiration happens, then what? So that's the things. So we recommend gastric ultrasound, but we don't make further recommendations because it's hard to say.
So I think you have once again emphasized that the ultrasonography is one of the anesthesiologist's main armament area. Probably it's a replacement of stethoscope. Great insight from you. I really learned a lot, and probably I'm sure that many of us would have got great insight. And back to Murali, our IJA podcast host for further proceedings.
Thanks a lot, Rakesh ji. Hari, thanks a lot for joining us. I know the busy schedule that you are in, but the editorial has sparked so much of interest. We said we have to speak to the person who wrote the editorial and get more insights. And this is our 20th episode of IJA podcast, and I'm very honored. And as a team, we thank you for joining us, and we wish you more energy, continue teaching POCUS, ultrasound, and regional anesthesia across the world. And I'm sure you will contribute much more to the future of Indian anesthesia by coming here and teaching and conducting more workshops. So thanks a lot for joining us. And the next episode that we have, the Editor's Insights, we have one of the doyens in regional anesthesia, Dr. Vincent Chan, will be joining us to talk something very relevant to the present day practice of what do local anesthetic plasma levels mean. Where is the therapeutic threshold? Where is the toxic threshold? And with so many blocks being given, how should we dose regional anesthesia techniques with local anesthetic? So that is the next episode coming up next week. And thanks a lot, Dr. Hari, for again joining us. Any final words, last few words that you would like to say to all our listeners?
Thank you, Murali. Thank you, Rakesh. Always happy is my home for Indian society. Anytime. Yeah, when Rakesh asked, I said, I will definitely do it. That's what I always say. I'm very happy to see in the recent Aurora meeting, a dedicated focus track has been given all the days. People are enthusiastic, people are learning. So I always say it is a simple bedside tool to risk stratify your patients, to help to narrow your differential diagnosis in different situations, to come to a diagnosis. As any diagnostic test, it has its own limitations, false positives, false negatives. You get trained, you get your expertise, it will help the patients. This is one of the revolutionary tools that will help patients in the perioperative period. I always say from now, if you are an anesthesiologist, if you are not good with ultrasound or point of care ultrasound, you won't be doing enough justice for your clinical care for your patients. Please learn, please be in the revolution, be moving forward. And I request all the ISA, Aurora to continue the same and do a wonderful job in this regard with point of care ultrasound.
Thank you. Thanks a lot, Hari. And for those people who would like to learn more, as I mentioned earlier, he's very active on Twitter, so you can follow him on Twitter and learn more. So thanks again for all of you for joining and listening or viewing this podcast. So till next week, till we get the other Editors Inside episode, for all of you, stay safe, stay curious, and keep learning. Thank you very much.
Thank you.